Welcome to another MDC question style walkthrough. If you are new to these sessions, what we do is we take a question from the MDC recall question bank and we discuss it together. I'm Dr. Akin Skuzi and I'll be taking you through today's sessions. Today's question says a young female with no known chronic medical conditions is being seen by a dermatologist for recurrent facial acne. She also has associated hirsutism and reports scanty menstrual flow. A gynecological assessment was conducted and the image findings are shown below. This is the image and the question says, what is the most likely diagnosis? The answer options we've been given are uterine fibroids, B, polycystic ovarian syndrome, C, hydatidiform mole, adrenal hyperplasia, and E, incomplete abortion. So as usual, we are going to start with the stem of the question first, try to pick up as much important and salient information from that as much as possible. Then we'll combine it with the image findings and try to put it together to make a diagnosis. What is of importance here, what we should pay attention to in the stem of the question is the fact that the patient has recurrent facial acne, which is relevant here, and that is one of the reasons he was actually being seen by the dermatologist. And there's hirsutism, which is excessive facial hair in a female, and she has scanty menstrual flow. So there's some form of irregularities or dysfunction in the menstrual cycle. Of course, of note, it's important that it's a female, obviously, and that she doesn't have any known chronic medical conditions. So no known comorbidities as it stands now. That is about it in terms of important things and that needs to be highlighted in the stem of the question. So let's see if we can read something from the image. This is the image we've been given. Typically, they will describe it to you what kind of image we are looking at. This is a pelvic ultrasound showing the ovary. In this is you are not expected to know the details of reading ultrasound in medical school, but there are some few organs that you should be able to pick up. For instance, the kidney, of course, there's a bladder and things like that. Uterus, the things that are very common. You should be able to pick them up from the ultrasound imaging. But typically, in the question, it will be stated and it will give you a clue on as to what organ you are looking at. But if you look at this image, what stands out from the image is this almost bean shape appearance structure here that we are looking at this stage, right? And that is what you should be focusing on. Now, what is of relevance is that inside the structure you have these multiple dark areas, ring or circular almost dark areas inside it. Okay, and there are multiple of these. There are multiple of these. You can see them all over there, right? These dark areas, in ultrasonography is described as anechoic. Anechoic means that absence of echo. Echo is we are referring to a reflection of something. So if it sounds, so the reflection of sound waves. Here we are talking about ultrasound waves, and anechoic, it means that these objects did not reflect the ultrasound wave. So what happens in ultrasound or in ultrasonography, you have the transducer, transmit the ultrasound wave to the body, or to the object. In this case, the body, which is done as a pelvic ultrasound. Various organs reflect the sound waves differently based on their consistency. So things that are more denser tend to reflect the ultrasound waves more. And so when you have more of the reflection of the ultrasound waves, and that reflection bounces back and is picked up by the ultrasound probe or the transducer, and that generates the image. The areas that are light and fluid, for instance, do not reflect much of the ultrasound wave, and so they will appear to be much darker. And that's what we are seeing here. So in ultrasonography, anechoic areas usually suggest structures that contain fluids. So these dark areas that we've just identified are typical of a cystic lesion. So these are anechoic lesions, and are suggestive of cystic lesions. So if you've seen an ovary and you've seen all these multiple anechoic regions inside it, and then we said is the ovary we are looking at. So we can say that there are multiple cystic lesions within this ovary. We can't really tell the size of this ovary, but typically you should be able to measure the size of the ovary as well, and that'll give you a size and a clue on the volume of the ovary. And so those are the lesions, the cystic lesions that have been highlighted here. So now let's go back to our question to try and see if we can answer this question and see how much information we have from the imaging together with the stem. We've already highlighted these points previously. Let's try to see if we can answer this question with just the stem alone. Because sometimes what happens is that in OSCE, you may be given the image and be given just a little bit of the information, the clinical history, and you'll be asked to make a diagnosis from the image. And a subsequent question might be, what other questions or what other information will you want to find out, or what other symptoms? And that's when they will now expect you to put in these other clinical features. But in an MCQ question, you'll most likely have all the clinical features without the image. So you should be able to diagnose a condition with or without, the image. So you should be able to diagnose a condition without the image. And if you've been given enough information from the stem, or you should be able to make the diagnosis of the condition with just the image with some little clinical symptoms. So both cases, you should be comfortable in making diagnosis in any of those forms. So let's try to see if we can make a diagnosis from just the stem alone without the image findings. We've highlighted the important information here. What is important here is that these three features, clinical features, when stringed together, kind of give you, makes you begin to think of features that you see. For instance, recurrent acne and hirsutism. Facial hair are typically seen in men, and acne is also very common in pubertal boys. So there's a reason that is the case, and that is because of increased androgen levels. So when you begin to see these things in females, it means that the amount of androgen in the female is probably high, and that also can now interrupt with the menstrual cycle and causes the menstrual flow dysfunction, as we've seen here. So these three features put together suggest that there's some form of hyperandrogenism. So there's an increased androgen level in this patient. So with just that alone, can we try to see which condition can we rule out? Always start with the ones you can rule out. Don't rush. Don't be hasty in picking up answers. Try to rule out things that you think are obviously wrong. And so even when you're not sure and you're able to rule out with confidence some of the options, now it reduces the amount of guess, and increases your probability, even if you are going to guess between the options that are left. So we are looking at conditions that present with hyperandrogenism, and which ones we can rule out. Uterine fibroids, so that's in present with hyperandrogenism, and in uterine fibroids, we might also actually have heavy menstrual flow and not what is described here as scanty. We can also rule out hydatidform, which also doesn't present with hyperandrogenism. Incomplete abortion does not present with that either. So those three options kind of rule out, and that leaves us with just two alone. So even if it's in an MCQ question and you've just had only the stem, and you've been given just the stem of this question without the image, and you're asked to make a diagnosis with just this alone, you've ruled out. If we're going to guess out of 5, that gives you a 20% chance of getting a correct answer from a guess. But right now we are now left with a 50-50 chance because we've just ruled out 3 of the options and we're now left with 2. So that increases your chance of getting a correct answer, even if you are just making a guess. But that's going to be an intelligent guess because you've confidently ruled out 3 of the options. Now, the question, in order not to be ambiguous, gives us an image, and that is going to help us in making the diagnosis. That is where the image findings now become relevant. So now let's see We said that in the image, we saw an ovary, and then we saw multiple cysts within the ovary. And multiple cysts within the ovary with a patient who has hyperandrogenism is more suggestive of a classic condition, in this case, your polycystic ovarian syndrome, and then that rules out the adrenal hyperplexia. So your answer here is a polycystic ovarian syndrome, but without the image finding, that would have been very difficult, isn't it? Because adrenal hyperplasia also present hyperandrogenism. But of course, that will typically present with extreme versions of these features, which they'll have viralizations of viralization, which is like more extreme version of hyperandrogenism and all of that, and other features, and probably might even come way earlier than this patient has. But yeah, I mean, with the combination of the image findings, our answer here is a polycystic ovarian syndrome. So, which other clinical features do you see in patients with polycystic ovarian syndrome? As I said, polycystic ovarian syndrome is also known as your Stine-Leventhal syndrome. It's a common hormonal disorder typically seen in females and typically tend to present in adolescents. And the features that they present with are the features of hyperandrogenism. And these will manifest clinically with menstrual irregularities, signs of insulin resistance, and other skin conditions. In this case, the skin conditions were actually what this patient thought to be more worrisome, and that's how come they started from a dermatologist first and subsequently ended up at a gynecologist. So your menstrual irregularities, you're looking at amenorrhea. So the amenorrhea here could either be primary amenorrhea or secondary amenorrhea. Primary, if it occurs, if the PCOX comes way earlier, prepubertal, and so in this case, this patient will not have had even their first menses, so they'll be amenorrheic straight away, and that will be primary amenorrhea. Or it could come after they've had their first or few years of menses, which sometimes might actually be irregular, and then subsequently become amenorrheic. Then you have oligomenorrhea, as you've seen in this case, scanty menses or irregular monthly flow. Then you have issues of fertility. So either they are completely infertile or they have difficulty with fertility as well. Then you have insulin resistance. Insulin resistance as one of the clinical features manifesting with your metabolic syndrome. So you have insulin resistance, obesity, hypercholesterolemia. All of these things can also arise in patients with PCOX. And you have your metabolic dysfunction, associated steatotic liver disease, which used to be called your non-alcoholic fatty liver disease. You have fatty deposit in the liver, and this is because of increased amount of energy in the body. You have high amounts of sugar circulating in the body, and there's resistance to insulin. That sugar is not being taken up. All of that gets converted into fats, and gets stored in the liver. So you have that. This is not from somebody. It's not what is seen in alcoholic fatty liver disease. It's a non-alcoholic, which is why it's called non-alcoholic initially. But there are other conditions that can cause that fatty deposit, like from drugs or other injuries, can cause fatty deposit. So it is now more the current name of that is now metabolic dysfunction associated steatotic liver disease. If you hear that is the same as a non-alcoholic fatty liver disease. Those are also some of the clinical features you can see in patients with PCOX. Then you have your skin conditions, as we've seen in this patient. You have hirsutism, which is increased facial hair. In the female, you have acne vulgaris, which we've seen in this patient too as well. You have oily skin. These are all features suggestive of increased testosterone or androgen in the body. You have your male pattern hair loss, and in the extreme form, you have virilization, which is like a very extreme version of hyperandrogenism, where you have increased muscle mass, the typical male secondary sexual characteristics, deepening of voice, increased muscle mass. You have your male pattern hair loss, and all of those things are all features that you can see. But are typically not very common in peacocks, but it can be seen in the extreme version. Then you have your, acanthosis nigricans. These are like typical things that you can also see in peacocks and are seen suggestive of insulin resistance. And an image of that is what is shown here. You have these hyperpigmented the vert lesions that are typically seen in flexural regions of the body. So like the axilla, the groin, and also in the neck region, you can see these things there. And the underlying pathology, pathophysiology here is that there's increase, there's hyperinsulinemia. We've stated that there's peripheral resistance to insulin. And the body perceives that as low insulin and kind of just keeps producing more insulin. So you have hyperinsulinemia, and hyperinsulinemia can now cause, this epidermal growth, overgrowth, or hyperplexia, and these are some of the things you see as evidence of that in a patient. There are other issues like psychiatric conditions, for instance. Some of these patients they might come depressed, with anxiety, and it's all tied to all these either the hormonal disorders and the clinical features that we've described. So for instance, an adolescent with facial hair, and all of these can trigger them into developing depression. But the hormonal disorders itself can also predispose them to developing these psychiatric conditions. So depression and anxiety, these are things that you should look out for patients with peacocks. Right. So how do you diagnose a patient with peacocks? We've mentioned, your history is one, your clinical examination, and of course your investigation. But there's a criteria for which a patient should meet in order for you to say, okay, yeah, this patient has peacocks. And that criteria is called the Rotterdam criteria, and the criteria is made of three clinical criteria, two of which must be met for you to say that at least two of it must be met for you to say that the patient has peacocks. One of that is oligo-ovulation or anovulation, and this will typically present in your history as issues with fertility, so infertility or difficulty conceiving. You have hyperandrogenism as you've seen in these patients, and this hyperandrogenism could either be clinically evident, so with features of acne, alopecia, or hirsutism, or the other features of hyperandrogenism, or laboratory features, which when you do, you probably see an elevated level of androgens, or in this case, for instance, testosterone. But typically, you don't necessarily need to have an elevated levels of the hormone to confirm that the clinical features of hyperandrogenism alone is enough for you to say, to say that there's hyperandrogenism. And then you have your enlarged or polycystic ovaries, uh, which is evident, which can be evident on ultrasound. Before you now confirm, or before you use this criteria, you have to rule out other conditions that other endocrine conditions that might also present with features, especially like the hyperandrogenism, for instance. So you have to rule out thyroid diseases. So you have to do your test, your TSH test, hyperprolactinemia. You have to rule out. Do your prolactin, investigate for these conditions. And especially for people who are patients who are amenorrheic, you have to be sure they are not pregnant. So your urine HCG is very important. Then you have to rule out any other hypothalamus pituitary gonadal axis dysfunctions, for instance, or patients who are having some kind of a premature menopause. So your LH, FSH hormones are very important. Levels are very important. You have to be sure that this patient is not going into some form of premature menopause because of a dysfunction of the hypothalamus pituitary gonadal axis. So you check, you do your serum levels of LH and then your serum level of FSH. Typically in PCOX patients, the LH levels are very high compared to the FSH, and so you have a ratio of greater than 2, and that is something that is very relevant when you're making a diagnosis of PCOX. And you screen for other comorbidities, as we mentioned. But when at least 2 of these criteria is met, then you can say that the patient has PCOX. How do you manage patient with PCOX? There's the general principle for patients with PCOX is generally to start with lifestyle modification. We are talking about dietary modification, exercise to lose weight. We mentioned that there are increases of developing metabolic syndrome, and obesity is one of those features. So you are trying to help them keep their weight, BMI of less than 25. Um, and that can be achieved by the exercise and dietary modification. So reduce food intake and your exercise, and screen for other comorbidities like hypercholesterolemia, type 2 diabetes, hypertension, and yeah. So those are like general uh treatment recommendations that you give of all patients with PCOX. Then you can have specific treatment measures that you can give to patients depending on their fertility wishes. So for patients who are planning to conceive, to conceive or have give birth, the treatment option is slightly different from those who are not planning to give birth or to conceive. So for those who are not planning to conceive, their main concern generally is the features of the hyperandrogenism that we've mentioned, the hirsutism, the acnes, those, and then the menstrual irregularities are their main concerns. So those are the ones you are trying to treat the underlying or any other comorbidities that they may have. So for them, the first line is usually combined oral contraceptives, and combined oral contraceptives in these patients have the benefit of treating the symptoms of the hyperandrogenism, and the menstrual irregularities who are also controlled. And so combine oral contraceptives, first line treatment for patients who do not intend to conceive and have PCOX. It also has the added benefit of reducing the risk of developing endometrial, hyperplexia and subsequent endometrial carcinomas. The acnes are well controlled, and all the other features of the hyperandrogenism are also controlled. Metformin can also be prescribed for patients, especially those who are overweight or obese, and it has the benefit of also help treat the metabolic syndrome that might arise. It also has an other benefit of improving the menstrual irregularities and the hyperandrogenism features. For patients who intend to get pregnant, their main aim is, they want to you want to be you want them to ovulate so that they can conceive. But for that to happen, you want to be sure that all other comorbidities are being dealt with. So you need to identify all the other comorbidities that they may have, and that includes weight, excess weight. So they have to also, lose weight, go on a lifestyle modification to lose weight, and then you treat any other comorbidities that may have type 2 diabetes, cholesterol, high BPs. All of that should be treated, and you induce ovulation. And the first line medication for ovulation induction in this patient is a clomiphene citrate. Clomiphene citrate is an anti-estrogen medication that it blocks estrogen receptors at the hypothalamus level. And so what happens is that once you have clomiphene citrate blocking the estrogen receptors at the hypothalamus, the negative feedback of estrogen on the hypothalamus is cut off, and you have an increased release of gonadotropin releasing hormone from the hypothalamus, and that stimulates the pituitary to release more of the LH, FSH, and that kind of increases the chances of the maturation of the follicles in the ovary and subsequent ovulation. And that's what clomiphene citrate does, and it increases your chances of ovulation and subsequent, fertilization. Other medication like metformin, as I mentioned, also has that benefit, and especially is good for patients who are overweight as well. Other options like laparoscopic ovarian drilling, which basically cuts off chunks of the ovaries to reduce the amount of androgen that is being produced from the ovaries. And so the idea is that once you drill these holes and take pieces of these ovaries, it kind of reduces the amount of androgen that is present in the body, and it gives the body a chance to restabilize the LH FSH ratio. Now FSH is now increased, and that has a chance of stimulating the follicles to mature and subsequently ovulate. And that is one other option. And the other option, which is not very common in our setting because, of course, cost is one, and the facility and resources for IVFs are not very common, but that is an option that is available in some few centers in our setting, but it's very expensive. And of course, you know, the guarantee of fertilization is not assured. Of course, The other option, which is not stated here, is adoption. You can always adopt, which is another option of getting baby, but that is not stated here. If you want to know. Complications of peacocks. We've mentioned that um, there are increases of developing metabolic syndrome. And metabolic syndrome, we said, is characterized by obesity, hypercholesteremia. We've mentioned the insulin resistance that we've talked about, and all of that increases your cardiovascular risk of developing cardiovascular diseases. And you have type 2 diabetes as well as one of the complications. You can have you have increases of developing malignancy, especially endometrial CAs, because of the increased estrogen. So you have unexposed, on sorry, un unopposed estrogen levels, as you see in patients with peacocks, and the estrogen here is coming from peripheral adipose tissue producing estrogen, and they have very increased level of estrogen, and that stimulates and causes endometrial hyperplexia, and that increases the risk of developing endometrial CAs. Other cancers like ovarian CAs, pancreatic, kidney, and actually other endocrine CAs, especially, they are also at increases of developing these customers as well. So yeah, I mean, we have a dedicated module where we talk about, go into details on PCOX and other gynecological conditions. Make sure to check it out. This was just a recap of the question that was taken from the MDC Recall question bank. As I said, this question can come either as an MCQ or as an OSCE, and I hope this information was beneficial, and gave you some you were able to learn something from it. Yeah, see you in the next session.